everyone. In this session, I will speaking on how to interpret the antibiotic susceptibility test reports. Bacteria develop resistance against different categories of antibiotics through development of antibiotic resistant genes. Among the genes, one such commonly developed genes by the bacteria are the beta-lactamases. Beta-lactamases, as per Ambler classification, are of different types. On the basis of this different types of beta-lactamases, we can see which antibiotics could be prescribed. For example, if it is a narrow spectrum beta lactamases, which is class A, this narrow spectrum beta lactamases hydrolyze penicillins. So penicillins will be resistant in narrow spectrum beta lactamases. These are more commonly seen in Enterobacteriaceae, and examples of such narrow spectrum beta lactamases is TAME and SHV. If the beta lactamases are ESBL, that is extended spectrum beta lactamases, it is class A. It also hydrolyzes narrow and extended spectrum beta lactamases. Now, what are extended spectrum beta lactamases? These are the cephalosporins. So, when an ESBL is isolated or identified on testings, that means cephalosporins will be hydrolyzed into TB resistance. Examples of ESBL enzymes are TAME, SHV, and it is seen in Enterobacteriaceae. Another example of beta lactamases is the serum beta carbapenems. They hydrolyze carbapenems. That is, carbapenems will be resistant if these resistant genes are produced. This is these examples of this serum carbapenems is KPC and IM, and this is commonly seen in Enterobacteriaceae. Another beta lactamases is metallo-beta lactamases or MBL. They are also capable of hydrolyzing carbapenems, and carbapenems are resistant here. Examples of MBLs are VIM, IMP, and NDM. This is commonly seen in addition to Enterobacteriaceae, Pseudomonas, and Acinetobacter species. Other type of beta lactamases is cephalosporins. It is class C. It hydrolyzes cefamycins such as cefoxitin and oxyimmunobeta-lactams. Examples of cephalosporins is MC enzymes. They are commonly seen in Enterobacter, Pseudomonas, Citrobacter species. Other type of beta lactamases is oxa. It hydrolyzes oxacillins and carbapenems and oxyimmunobeta-lactams. Example is oxa, and it is commonly seen in Enterobacteriaceae and Acinetobacter. So this is how the Ambler has classification mentions about the different types of beta lactamases. Accordingly, the antibiotics can be identified for the treatment. On basis of these enzymes, the corresponding antibiotic class could be selected for the treatment. For example, if it has been ESBL, then the drug of choice will be cefamycins or carbapenems. If it has been MC producer, it will be against type 4 cephalosporins and carbapenems. If it has been carbapenems producer, then the drug of choice will have been monobactams. So this is how, based on this and identified antibiotic resistant genes, the different classes of antibiotics could be selected for treatment. We also have novel antibiotic agents, combinations of antibiotic agents, which could be used against different classes of different types of antimicrobial resistant genes and against different type of bacteria. For example, Acinetobacter avibactam is active against KPC, NDM, OXA, carbamazine-resistant Pseudomonas, and Pseudomonas multiple. But however, it is not active against carbamazine-resistant Acinetobacter baumannii. Similarly, ceftriaxone avibactam is active against KPC, OXA, carbapenems, but it is inactive against NDMs and Pseudomonas multiple. So this chart can be used for therapy against different classes, against different types of bacteria producing different classes, types of antimicrobial resistance genes. We also have this beta lactamase inhibitors like avibactam, tazobactam, vaborbactam, relebactam, which has shown activity and against different classes of antimicrobial resistant genes. For example, if you see tazobactam, it has no activity against KPC, but is active against SHV, TAME, and CTX, while avibactam is active against all these class A antimicrobial resistant genes. Similarly, vaborbactam and relebactam. However, avibactam will have no activity against MBL. Similarly, tazobactam, vaborbactam, relebactam will have no activity against MBL. While for MC, avibactam is active, but tazobactam will have no activity, while vaborbactam, relebactam will be active. So this is how this beta lactams inhibitors have different activities against this class of antimicrobial resistant genes. Let us understand. We have seen about the different resistant genes and the novel antibiotic agents. Let us understand through a case study the application of sensitivity testing results for antibiotic selection. Say patient named XYZ, 49-year-old, admitted to nursing home with complaints of fevers and coughing, put on medications like Coamex, azithromycin. He is admitted to a hospital. It trans ET secretions escalated and its skilled Klebsiella pneumonia. Sensitive report of the Klebsiella pneumonia looked like it was resistant to all the antibiotics except colistin and ceftazidime avibactam. The lab result had indicated the patient is infected with Klebsiella, sensitive to colistin and ceftazidime avibactam, on which antibiotic will you choose? Since we had to, in this case, we had to see which the pharmacokinetics and pharmacodynamics of the antibiotics. Colistin, there is no universal dosing formula. It is nephrotoxicity. It doesn't penetrate into lung parenchyma. So seeing such pharmacodynamic parameters of the antibiotics, we have to choose the appropriate antibiotic. Here in this case, ceftazidime avibactam is selected as compared to in relation which would be better than colistin in this case of a respiratory tract infection wherein Klebsiella pneumonia is isolated. So take another example. If it is secretions where Pseudomonas aeruginosa had been isolated, when we see different antibiotics are sensitive to. In such case, it becomes difficult to identify the antibiotic to select the antibiotic for the treatment. Application of some few rules. There are rule number 1, 2, 3, and 4 that I will be sharing here. Rule number 1 states that always start with a beta-lactam antibiotic. For any therapy, always start with a beta-lactam because it is active, especially in severe infection. They have to base data for their activity, except in case of atypical infections. Rule number 2 says that do not compare MICs. As we have seen in the previous sessions, that every antibiotic has a different serum concentration, tissue concentration, of pharmacokinetics and pharmacodynamics. Some antibiotics are time dependent, some antibiotics are concentration dependent, some are AUC by MIC dependent antibiotics. So do not compare the MICs. Refer to the breakpoints and select the antibiotic. So this is how the chart of the time dependent, concentration dependent antibiotics looks like. Want to go into the details? We'll see in the next sessions about in detail about this antibiotic dosing. Rule number 3 states that if the antibiotic is reported sensitive, you can use the drug. However, if the drug doesn't get to the site of action, doesn't achieve the pharmacodynamic parameters, doesn't have any inducible resistance, patient-specific factors doesn't limit it, drug cost is an issue, then avoid such antibiotics. That always speak with the microbiologist, and there should be healthy, strong interactions between microbiologists and the clinicians regarding the testings. Microbiology always has more information than what is reported. They have the results before that is reported in the computer. So always refer to the microbiology lab for further information. So that was all about in my session. In the next sessions, we will see how to in details about how to interpret the sensitive results. That's all. Thank you.